This is a phase 2 trial. It's called the CLL-BAG trial. The name composes of the beginnings of the 3 different drugs we use. The first is the bendamustine, which is only used as a debulking in the beginning for patients with a higher tumor load. And then it's followed by an induction and maintenance phase where we combine 2 novel agents. One is the BCL2 antagonist venetoclax and the CD20 antibody obinotuzumab. It's a phase 2 trial, and because we wanted to evaluate this combination in real life, we included an all-comer population. So we have first-line and relapsed refractory patients, we have fit and unfit patients, and we have patients with high-risk cytogenetics. So basically, all patients that show up in your department were able to be included into that trial. So the idea of combining these 3 agents is based on the following. At first, we wanted to have a debulking for patients with a higher tumor load. So these patients received 2 cycles of bendamustine, which is a chemotherapeutic agent which has a good tolerability. Afterwards, the 2 agents are combined in an induction and maintenance phase. First, we started with the CD20 antibody in order to further reduce the tumor load, especially the lymphocytosis of the patients. And only from the second cycle onwards, we started with the venetoclax with a slow dose ramp up over 5 weeks, as it was already established in other trials. Combining these 2 agents, the idea was just these 2 agents, I would say, are the most efficacious which are available for the treatment of CLL. And combining the 2, the idea is just to achieve much deeper remissions in the patients. Because one of the goals of the trial was to stop treatment once patients have a very deep remission.
Okay. And what kind of safety was associated with having all 3?
So for the 45 patients who started with the bendamustine debulking, we only saw infections and cytopenias as expected with the bendamustine debulking. For the 66 patients who then received induction treatment, there also we didn't see any cumulative or unexpected toxicities. Patients had cytopenias and infections. This was in line with which was previously published for the venetoclax, so the obinotuzumab didn't add any toxicity to that drug. Other more common adverse events were infusion-related reactions in the beginning with the obinotuzumab administration. There were some secondary primary malignancies, mainly skin cancers. I think one very important finding is we didn't see many tumor lysis syndromes, which is a problem associated with venetoclax. There were only 3 cases. One occurred during the bendamustine debulking. One occurred with obinotuzumab in the beginning. And only one occurred at the dose ramp-up of venetoclax in a high-risk patient. All of these tumor lysis syndromes were only laboratory TLS, and they all were only grade 3 and resolved very quickly. So no problems with tumor lysis syndromes in this trial, and I think this is based on the sequential start of the different drugs.
I was just about to ask on the importance of the timing of these 3. If you were to change the scheduling one before the other or bring them closer together further apart, do you think that would impact outcome significantly?
Well, I wouldn't start with venetoclax and obinotuzumab at the same time point, because both of them are very potent drugs, and what we see with the CD20 antibody is that the lymphocyte count goes down very rapidly, and the same applies for the venetoclax. So if we do that together, I think that's not good to control There is another trial where they did it the other way around, and that worked as well. The primary endpoint of the trial is the overall response rate at the end of induction treatment. So that's after 6 cycles of combination of venetoclax plus obinotuzumab. And the overall response rate we saw in this all-comer population, let me remind you, half of the patients were treatment naive, but there were some very heavily pretreated relapsed refractory patients. Some had even undergone allo stem cell transplantation. 1/3 had high-risk genetics, 2/3 were IGVH unmutated, so it's a difficult to treat patient population. The overall response rate was 95%, which is very good. What's exciting is the MRD negativity rate, and this was 87%. And even more exciting, I would say, is that we didn't see any differences, any important differences between first-line and relapsed refractory patients, and also among the patients with deletion 17p, TP53 mutation, we had an MRD negativity rate of 70% in the peripheral blood, I have to say. It's not all bone marrow.
And how long will the follow-up for this trial be?
It's an ongoing trial. So far we have documentation of most patients that they started with the maintenance phase, and about half of the patients were already able to stop treatment, and most of them already stopped because of a deep remission with MRD negativity. Ongoing follow-up will, I hope, show that the rate of complete remissions will increase, and also maybe the rate of MRD negativity, especially from the bone marrow. I hope that we will get more samples over time. And then the follow-up of this trial might help to answer the question if it's really feasible to stop treatment if patients are in a very deep remission.
Well, you did mention, and I would like to follow up, the secondary skin cancers there. How much of a risk is that? Is it something patients should be aware of?
It's only 4 patients, so it's not that much, and it's something that we also see in a lot of other trials. And these skin cancers, most of them occurred rather early in the beginning of the trial, so I would say that they were pre-existing. It is something that is relevant for all lymphoma, and especially for CLL patients, because they have some disturbance of the immune system and they have a higher likelihood of developing any other cancer. So when I talk to my patients, I always tell them to have their screening examinations done at the dermatologist.
Well, you mentioned other trials where they've changed the arrangement and follow-up. Are there any plans to expand?
The combination of venetoclax and obinotuzumab is currently evaluated in phase 3 trials already. There is the CLL-14 trial, which already has completed recruitment. It's a trial in first-line setting of physically unfit patients, so it's the elderly comorbid patients. And in that trial, we compared venetoclax obinotuzumab as the experimental arm to the current standard chlorambucil obinotuzumab. In addition, in the end of last year, we started recruitment for another huge European phase 3 trial, which is a 4-arm trial, which also contains the current standard for physically fit first-line patients. It's FCR or BR, and one of the experimental arm is the combination of venetoclax obinotuzumab.